all of all of you feel enriched and fulfilled. Thank you for being a part of this evening. The talk for today is role of molecular testing in hemato-oncology practice. This is not moving. This is not moving.
Just stop sharing the screen once and then share it again.
Okay. Is it moving now?
It's nothing is visible right now. Have you shared the screen?
Uh, एक second.
Ma'am, kindly share it again.
Okay. Can anybody see the screen now?
Yes, screen is visible. Just make it full screen. Yeah.
Okay.
Now it's moving.
Okay. Thank you. Okay, so molecular testing in hemato-oncology has a role in diagnosis and subclassification, risk stratification and prognosis, helps in deciding therapeutic options, and is also useful for MRD monitoring. The various molecular techniques can be divided into DNA and RNA-based assays. The RNA is first converted into cDNA, which is used further for subsequent testing and analysis. The RNA-based tests include reverse transcriptase PCR, real-time quantitative PCR, Sanger sequencing, and NGS for fusion transcripts. And DNA-based assays include conventional PCRs followed by fragment length analysis and or Sanger sequencing. This fragment length analysis can be used for detecting mutations in myeloproliferative neoplasm and AML, BLL, etc. We'll see everything in the following slides. DNA-based assays also include NGS for point substitutions, insertions, deletions, copy number alterations, structural variations, kinase domain mutation analysis, and the latest evolving concept is that of NGS MRD. We'll deal with all these in form of simple cases. Let's look at the first case scenario. It is a very simple case of a 22-year-old male who is presented with splenomegaly and high TLC. The bone marrow aspirate findings are suggestive of myeloproliferative neoplasm in chronic phase, which means you have granulocytic preponderance with less than 5% blasts. You go ahead and do a FISH, which is positive for BCR-ABL. You can see two yellow signals and one red and one green signal. It means there are two yellow signals in the dual fusion probe is indicative of positivity for BCR-ABL. So the diagnosis can be confirmed on the basis of the FISH that it is a CML in chronic phase. Now, the question is there any other relevant test which needs to be done now or will stop here? And if yes, which test, why? So the answer to it is we should do an RT-PCR for BCR-ABL because we need to know the transcript type at baseline so that we can do the MRD monitoring at follow-up time points. How we interpret this test is, this is the gel electrophoresis picture. The two commonest CML transcript types are E13A2 and E14A2, which correspond to the P210 oncoprotein, and E1A2, which corresponds to the minor transcript P190 oncoprotein, which is commonly seen in pH positive BLLs. So if depending upon the base pair length of your size of your band, you can get to know which transcript type are you dealing with and which RQ assay has to be applied, whether P210 or P190. Okay, so now this patient's transcript type we assume is V13A2. This patient is started on imatinib 400 milligram. The patient comes to you 6 months later. At that time, you advise an RQ-PCR for BCR-ABL 210 because you know the baseline transcript. Now let us see what has happened. This is the RQ-PCR report. How do you interpret an RQ-PCR report? See, the BCR-ABL copy numbers are given, the ABL copy number is given, the IS conversion factor is given, and the final IS NCN percentage is given. The calculation is as such, you divide the BCR copy number divided by the ABL copy number into the conversion factor. That gives you your final IS NCN percentage. Now, how we are going to interpret this? This you will get help from this article, which is the ELN 2020 and later 2023 recommendations for treating CML, where you see at 6 month time point, you need to have your value is 7.786 in the report, right? And at 6 months time point, you are expected to have a value of less than equal to 1%. And this is lying in the region of warning, which means suboptimal response. So now there is a need for testing this patient because the patient has not shown optimal response to imatinib. The reason has to be found out. So how are you going to advise this patient further? The answer again is a KDM analysis, which you can do by Sanger or by NGS. In this case, the Sanger plot is being shown where there are double peaks. Normally in the sequence, in the ABL sequence, you have an ACT. AC is represented by the blue peak, and this gets replaced by ATT, that is the red peak. So this is a heterozygous mutation where your ACT has been replaced by ATT. And what does that become? That becomes T315I, where at the position 315, your threonine has been replaced by isoleucine and is located between the SH2 and SH3 contact residues. Now, what is the significance of this mutation? If you see this paper, the ELN recommendations, it has been there for a long time. This mutation makes your case resistant to almost all the first and second line TKIs, including dasatinib, nilotinib, and bosutinib. This patient will respond to ponatinib as well as asciminib. So what are you going to do now? So this particular case needs to be changed to ponatinib or asciminib. We have also come across cases where there are compound mutations when a person is positive. Hello. When a person is positive for two mutations, such as T315I and E255K. So how are you going to interpret such kind of a scenario? This can be interpreted as compound mutations involving T315I have been reported in asciminib resistant patients. So it means that if you have a combination of these two mutations, these patients are not even going to respond to asciminib. So for them, you have to plan BMT. The strategy has to be completely changed. So it is very important that you monitor the case well with RQ. You do the required analysis, KDM analysis at the right time point. Otherwise, the management will falter. So now there can be a question, which modality is the best to be used for KDM analysis? See, as far as the latest guidelines are concerned, if you have a reliable and validated NGS assay, that is best. But if you do not have that setup, the use of Sanger sequencing is also acceptable and does not represent an inappropriate management of patients. The same paper goes on to say that if you are detecting mutations by Sanger sequencing, or you are detecting more than 15% of transcripts by NGS or digital droplet PCR, you should immediately go for a change of therapy if your patient is showing resistance to TKI. If the transcript levels are lower than 15%, then you should, rather than following the wait and watch policy, you can go ahead with changing the TKI immediately if the BCR-ABL levels are persistently increased or the disease is progressing. So this is the approach one has to keep. It has to be very systematic. It has used so many tests. It has included RT, RQ. A simple CML has used an RT, an RQ, a Sanger, and an NGS. And in rare scenarios, you can also require RNA sequencing. So this is a similar case, exactly same case, where you are getting a FISH positivity for BCR-ABL. The case becomes a CML, but unfortunately, this is the well. So this case, according to now your interpretation, will be negative for E13A2, E14A2, and E1A2. How are you going to do this further, approach this further? And why is it happening? So the answer is, apart from the common typical transcripts, you have a lot of atypical transcripts because of different breakpoints between the ABL and BCR genes. So you need to apply a second set of atypical primer sets to detect these atypical transcripts. And see, for example, these are two cases which are shown. One is an E13A3 transcript corresponding to 170 base pair, and the second case showing E8A2 transcript corresponding to 465 base pair. So why knowing this information is important is because you cannot follow up these cases with the routine RQ-PCR assays. You need to either build a customized RQ assay specific to your case, which is not cost effective most of the times, or RNA sequencing can be done at follow-up time points. FISH is a good option till achievement of complete cytogenetic response. And a nested PCR, RT-PCR can also be done using the same set of primers which were used at baseline. So this is the complete picture. After CML, we now move on to the pH negative myeloproliferative neoplasms, which include these entities. Now, knowing the diagnostic molecular signature is important. Why is it important and how does it impact the management is something we need to discuss. So let's look at these first three entities. These are very common. Almost all of you must be knowing, must have read in your MD days also. P. vera, essential thrombocythemia, and primary myelofibrosis. They have one thing in common, that is JAK2V617F. P. vera, almost 95% of the cases are JAK2V617F positive. ET and primary myelofibrosis have almost 50 to 60% of cases which are positive. Apart from JAK2, these two also show CALR and MPL mutations, and they can be triple negative also. Then there is a case, and the significance of knowing this molecular signature is that if you have a JAK2 positive case, then you can use JAK2 inhibitor, ruxolitinib, in such patients if there is huge splenomegaly or you have a symptomatic disease. The patient is worsening, it has symptomatic anemia, etc. The next entity which is there is chronic neutrophilic leukemia. This entity also is strongly associated with CSF3R mutations, which is diagnostic and helps in clinching the diagnosis in cases where there is a differential of atypical CML. Then the next entity is chronic eosinophilic leukemia, where this entity is a diagnosis of exclusion. You need to rule out the AMLs with common fusions such as inversion 16. You need to rule out systemic mastocytosis. You need to rule out the other myeloid neoplasm associated with eosinophilia such as PDGFR A, B, FGFR1, etc. to label something as chronic eosinophilic leukemia. This becomes important because the PDGFR-A rearranged myeloid neoplasms will respond well to TKIs. We recently had a case who had presented with left-sided hemiparesis, and the moment imatinib was given to the patient, he was PDGFR-A positive. When the patient was given imatinib, his symptoms resolved within 1 week. So that shows the impact of correct management, correct molecular signature. Then there is juvenile myelomonocytic leukemia, which is newly added into this MPN category. The molecular signature includes PTPN11, CBL, RAS mutations, NF1 mutations, and the bone marrow transplant is the treatment of choice. However, the molecular signature does have a role in prognosis. There are menin inhibitors. There are many upcoming targeted therapies which are coming up in these patients also. So let's try to understand the pH negative MPNs through a case. It is a 56-year-old female who presented with fever and hepatosplenomegaly. The CBC showed anemia less than 8 gram per DL and the TLC was mildly raised around 20,000. The PS showed a leukoerythroblastic blood picture. The marrow was dilute, did not show increase in blast. There was granulocytic predominance with the left shift. Biopsy showed grade 1 fibrosis. So, we have this habit of putting a flow in almost all our cases if possible financially. So, this flow cytometry in this case showed 0.8%, CD34 positive.
और 2 हफ्ते बाद
CD4 positive, CD38 negative, 33 positive, 117 positive, and 7 subset positive blasts. So, see, up till now, we have this information that the patient has hepatosplenomegaly, but the TLC is in the range of 20,000. Anemia is also around 7.8. So, we know it could be a leukemoid reaction also. There is grade 1 fibrosis. But when you see that there are abnormal blasts or leukemic stem cells in your flow, you eventually get to a place where you're confident that this has to be a neoplasm. So that is one thing that we are assured, and we move ahead confidently about investigating further. So FISH and RT-PCR came out to be negative in this case. So probably we are dealing with a pH negative MPN. Now, before moving any further, we decided we'll do a simple test, that is JAK2V617F by ARMS PCR. And see, this is the wild peak. If you have a normal, if the JAK2 is negative, you will only have a wild peak corresponding to 229 base pair. If your case is mutant, you will have a peak at 279 base pair. Since this case is showing both mutant and wild peak, this will be labeled as heterozygous positive. You can also ask, why is a 450 base pair band present here? That is because this is a positive control band, which shows that yes, the reaction is all fine and the amplification has taken place properly. So on the basis of your morphology findings, the presence of driver mutation, you can label this case as a cellular phase of PIMF JAK2 positive. So the clinician will prognosticate the case further. It comes out to be intermediate 1 according to the DIPS or DIPS plus scoring. Plus is added when you have the complete cytogenetic karyotyping information available. If that is not available, you stick to DIPS. So do you think now we need to do something else in this patient? Do you think NGS may help in this patient? So in PIMF, there is a new scoring that has come, which is M.B.B.S 70 and M.B.B.S 70 plus. Plus again means you have karyotyping information available or not. So the M.B.B.S 70 score includes absence of CALR type 1 mutation, high molecular risk mutations like ASXL1, EZH2, SRSF2, IDH1 and IDH2. If you are using M.B.B.S 70 plus version 2.0, that also includes U2AF1, Q157. So if you apply this scoring in the patient, which includes, apart from these molecular and cytogenetic qualifiers, various other parameters which are already part of the DIPS scoring, then this case will upgrade into the high risk category. Why is it upgrading? Because you have now mutations in JAK2, NF1 and SRSF2 on NGS. And when you score that on the basis of your M.B.B.S, the final classification shifts from intermediate 1 to high risk. So is that going to impact your case and management? Obviously it is going to, because if your case is only intermediate 1, then if there is a bulky disease, you can add ruxolitinib. But your case is high risk. So the first treatment of choice is going to be, if the patient is transplant eligible, go ahead with JAK2 inhibitor to reduce the spleen size, alleviate the symptoms, and take the patient to stem cell transplant. If the patient is not transplant eligible, you start with ruxolitinib to alleviate the symptoms and reduce the spleen size. If the response does not come, you should shift to second line JAK2 inhibitors like momelotinib, etc. So there is a significance of all the molecular signatures that are there. So up till now, we have studied about pH positive and pH negative MPNs. Now we'll move to the next entity, which is MDS. As per the new WHO classification, the MDS has been described into MDS with defining genetic abnormalities and MDS which are only morphologically defined. Now, why do you think this classification would have happened? Is there any significance, or is there any impact on management? Yes, there is a significance, because if your case is 5q isolated 5q deletion is present, then your case will respond well to lenalidomide. If your case is associated with SF3B1 mutation, then luspatercept will work well in your case. If your case is biallelic TP53 mutated, this makes it a high risk and poor prognosis case, and the patient should be straight away taken for bone marrow transplant if eligible, and the bridging should be done by with hypomethylating agents. The significance of the morphologically defined MDS is based highly on the percentage of blasts. So one thing that you have to be very cautious about is whether you're reporting something as MDS increased blast or AML, because if you remember, the latest WHO has removed the cutoff for blasts. So if you say there are 10% blasts and it comes out to be NPM1 positive, you're going to label that case as AML and not MDS IB2. So that should be a very alert diagnosis. You should be ruling out all the defining genetic abnormalities, which include the common AML translocations, NPM1, SEPA, TP53, etc., to be able to label the case as MDS IB2. So let us try to understand MDS through a case. You have a 63-year-old female who has received 3 units of PRBC in last 3 months. The PS showed hypolobated neutrophils. The cellular imprint smears showed multilineage dysplasia, this time involving the myeloid and megakaryocytic lineage. The blasts are not increased. There are no ring sideroblasts also. So you can see some hypolobated megakaryocytes in the background. So on the basis of your morphology, you can label this case as MDS with low blasts for now, in the background of a history of cytopenias and transfusion dependence in an old lady. So the karyotyping result in this patient shows isochrome 17q and deletion 20. Some of you must be hoping that based on the hypolobated megakaryocytes, this could come out to be a deletion 5q. Unfortunately, it didn't. Then we went ahead and did an NGS in this case. Also, the flow cytometry was also used in this case, which showed 3.8% abnormal myeloid blasts and 1.8% leukemic stem cells. So I told you, when you have additional flow information, that strengthens your diagnosis in sophisticated cases where labeling a case as neoplastic can burn your fingers. So flow helped us in such kind of cases. And this case on NGS showed ASXL1, SRSF2, NRAS, KRAS, and GNAS mutations. So this case finally was classified as MDS with low blast. However, the supportive findings such as karyotyping, NGS flow cytometry made our case very strong. We were more confident. So as far as the confidence is concerned, it's all right. But now we move to a different case scenario where you have again bicytopenia and multilineage dysplasia, this time involving the erythroid lineage and megakaryocytes. You can see the binucleated erythroid and karyodexis in the background. This time your cytogenetics shows deletion 5q. Final diagnosis on the basis of findings till now were MDS with low blast and 5q deletion. So you will feel happy, I am sorted, nothing else is required. But you see the NGS report. We went ahead and did the NGS. We didn't want to be complacent. We didn't want to miss out on any information. So what we got is 2 somatic mutations in TP53 gene of almost same VAF percentage, 44%. So this was labeled as myelodysplastic neoplasm with biallelic TP53 inactivation according to the latest WHO guidelines. And I already told you that this is poor prognosis, a very high risk category. You define biallelic TP53 alteration in 3 scenarios. Either you have 2 TP53 mutations with similar VAF as is present in the present case, or you have 1 TP53 mutation which has a VAF of more than 50%, or you have 1 TP53 mutation along with a 17p abnormality, deletion or copy number loss of heterozygosity. So, according to the WHO also, you have to label something as low blast and 5q only when the MDS with biallelic TP53 inactivation has been ruled out. So, you know your final diagnosis is clear, established now. It is a biallelic TP53 mutated MDS. You go on to do the molecular IPSS. You have a revised IPSS on the basis of which this case was categorized as intermediate. But when you added the information of TP53 biallelic mutations in this case, your IPSS upgraded to very high risk. So you now know you have to treat this patient with hypomethylating agents followed by allo-FCT. So we move on to the acute leukemias, which in today's times rely heavily on molecular signature. See, the BALLs, they have so many molecular signatures. You are aware of most of them. Again, AML has so many fusions and mutations. So let us try to understand the cases through valid examples. You are seeing a 10-year-old male who is diagnosed on peripheral blood flow cytometry as BALL. You can see you have 45 dim, 34 positive blasts, which are showing 19 and 10 dual positivity. And the interesting point is it is showing 33 also. It is MPO negative and it is 25 very nicely positive. So when you get a BLL with 33 expression and 25 good expression, you should think of entities like pH positive or BLL or pH like BLL. So we went ahead and did an RT-PCR for BCR-ABL. Unfortunately, it came out to be negative. The FISH panel for all the common BLL translocations was done. That also came out to be negative. Now, then RNA sequencing was advised. And interestingly, what we saw was EBF1 PDGFR-B fusion was obtained. So that classifies your case into BLL with BCR-ABL like features. Why this is important to know? Because along with the conventional ISICL protocol or whatever protocol you're following in your institution, you need to add dasatinib to the regimen. Any TKIs? In BLS, they prefer to add dasatinib, and because of which the post-induction BMRD was 0.005%. So in this case, IKZF was also done, which came out to be positive. There is a 211 base pair band, which corresponds to deletion 4-8. And the significance of IKZF mutation is these are seen in 60% of patients with pH positive or pH like ALL, such as this patient, and they're associated with increased risk of relapse, therapy resistance, and inferior survival. So this case needs to be followed up in long run and seen how is it going to behave in terms of overall survival. It should behave poorly. But in today's times, because you have such targeted therapies available, the response is definitely better than what it was 10 years back. So moving on to the next case, it is a 50-year-old male who presented with bicytopenia and hepatosplenomegaly. Bone marrow showed flow cytometry showed features of AML with maturation. The FISH for the common AML translocations came out to be negative. We usually do a fragment analysis for the common AML mutations because, it takes time to do NGS. At least 3 weeks time will be required. But if if you give the status of FLT3, ITD, NPM and SEPA within 2 days, the clinician can take a side. He can apply for funds, and whether you have to plan your induction along with adding midostaurin or sorafenib also can be decided, and funds can be a drug can be procured simultaneously. So in this case, what we found was we had a 54 base pair mutant peak with an allele ratio of 0.67. This is the FLT3 ITD. Along with that, we saw 4 base pair insertion in NPM1, which corresponds to NPM1 mutation. So we further did a DNA sequencing that showed IDH2, NPM1 and SRSF2 mutations. So now the question remains, and RNA sequencing was also done to rule out all the rare possibilities that came out to be negative. So how are you going to approach this case? How will you finally classify this case and risk stratify this case? Because it is interesting, you have an NPM1 also, you have an AML MR mutation also. So the answer has been given by ICC, the International Consensus Classification of AML, which talks about the hierarchy. They say that AML with defining recurrent genetic abnormalities will take precedence over all other entities. So this case falls here because it is NPM1 mutated. So it will get preference over SRSF2 mutation. So you label this case as AML with NPM1 mutation. Further, if you do the ELN risk stratification based on 2022 guidelines, you see that usually NPM1, if it is without FLT3 ITD and has an SRSF2, it will qualify, it will not upgrade to adverse. But in our case, because this patient has NPM1 and FLT3 both, in such cases, your case will upgrade to adverse risk. So this finally becomes an AML with NPM mutation, adverse risk, and the treatment will be LOBMT in CR. For the good risk category, now you know that this category is the safest, but no, it's not like that. The AML, apart from all these changes, AML is very heterogeneous. So you should rely more on the AMRD results as suggested by the ELN recommendations, that you treat the patients and initial risk management will change during the treatment course based on the results of analysis of MRD. So MRD assessment in good risk patient becomes very important. The others are anyway going to behave badly and they will require allo-BMT in CR. So what are the different methods of detection of MRD in AML? They can be flow, they can be quantitative PCR for the fusions as well as NPM1 and WT1. The other exploratory methods, NGS has more or less been established, and it is also gaining its ground very strongly and very fast. So, and apart from that, digital PCR also is coming up. So we need to look at some of the ELN recommendations. For AML MRD, you need to report anything more than 0.1% on flow cytometry. But even if it is less, you need to report that. For qPCR, if you want to label something as positive, you need to have a CT value of less than 40 in 2 out of 3 replicates. And the housekeeping genes should be at least more than 10,000. In NGS MRD also, the clinical cutoff has been taken as 0.1% VAF, but we have observed, the studies have observed that anything less than 0.1% also has been associated with adverse outcomes. So you should report any number, any cutoff of MRD, whichever you get in your clinical practice, because that ultimately will result in relapse if not handled delicately. The other things that you need to keep in mind is when you're doing AML MRD by NGS, you should not consider the germline mutations like ANCAD26, SEPA, DDX41, ETV6, GATA2, RUNX1, and TP53 for MRD assessment, because these mutations are going to be persistently present because they're germline in origin. You should also be aware of the DTA mutations, which are the chip mutations. You should not use them in MRD analysis. You should also be cautious if you are using some targeted therapies like FLT3 inhibitors and IDH1, IDH2 inhibitors, because eventually these inhibitors will target and the FLT3 clones and the IDH clones will disappear, but still your case can be MRD positive based on the other mutations that are present in that case. So these are some of the riders you should be aware of. Wherever the fusions are present, you should preferably do a RQ-PCR. So the recommended time points for doing MRD testing and the clinically relevant actionable time points are shown in this diagram. The clinically actionable time points are shown in red. So you see, after 2 cycles of your starting therapy, if MRD is positive in bone marrow by flow cytometry, that is the time point when you can escalate your treatment. Apart from that, at the end of therapy, if you have more than 2% MRD or the log reduction is less than 3 to 4 or flow is MRD positive, you need to intervene. At follow-up time points also, the guidelines are more or less similar. So this you should remember. You should not be you should not be too ecstatic. You should not be too docile. You have to find a middle way when to act in the best interest of the patient, following the strict guidelines that are available. Now, one more thing, because NGS MRD is upcoming, we need to know a little more about it. The ELN recommendations have set the cutoff at 0.1, but the latest paper about this NGS MRD said that 0.0024, if you take that VAF percentage as your cutoff and you consider a higher VAF percentage as positive, these patients were seen to be associated with shorter overall survival and shorter time to relapse. So 0.1% is not the defining thing. You will have lower cutoffs as the MRD evolves during the upcoming years. The next case is that of an 18-year-old male with bicytopenia splenomegaly. Your flow is saying this is a case of AML with minimal differentiation. Your FISH shows monosomy 7. It is negative for all the AML associated fusions. Your PCR-based assays are also negative for FLT3, ITD, NPM, and SEPA. Now, on the basis of monosomy 7, you can label your AML as AML MRC, even if these somatic defining mutations are not present. So, but So up till now, you will say that I have an AML, I have a monosomy 7. Why should I do a NGS? But see what happens. Your AML MRC with monosomy 7, when we went ahead with the NGS, we saw that there were EZH2 and ASXL1 mutations, which is not a big deal. These are also AML MRC mutations only. And you know AML MRC is a high risk subtype. So your prognosis is also not going to change. The treatment is also not going to change. But what we also saw was you have a high VAF percentage of pathogenic GATA2 mutation, 51.75%. So this patient's history was revisited, and there was a history of frequent infections since childhood. There are also GATA2 deficient cases we have come across which have shown multiple episodes of infections with Mycobacterium acellularare. There have been history of sibling or parent death. So these things are classical histories that we come across. Some patients have had hearing loss. So possibility of GATA2 deficiency was suggested in this case. This complex of myeloid neoplasm, GATA2 mutation at a high VAF, monosomy 7 is considered to be monomax syndrome. And germline testing was advised in this patient as per the latest BGH guidelines. The BGH guidelines say that if you've come across a point mutation of more than 30% or an insertion deletion of more than 20%, you should suspect a germline mutation and advise accordingly in the patient. If you're suspecting germline, you should ask for patient sample when he's in remission, or you should test for germline mutations in the sibling or the parent to confirm the diagnosis, because their approach will be completely different. But the mutations are there to stay. The management has to be very delicate. The patient's will be immunocompromised also most of the times. So next, moving on to the next case, it's a 35-year-old male presenting with pancytopenia and splenomegaly. You can see some projections here, which are seen in occasional cells. You do a flow, you see a high side scatter in the 45 bright region. You see kappa restriction in the 1920 dual positive cells, which are shown in red. You put up the additional hairy cell markers and see 11C, 103, 123, and 25 being expressed. So more or less you are, on the basis of your morphology and flow, sure that it is a case of hairy cell leukemia. But you should not leave the case at that point. If you have a simple test available in your lab, you should go ahead and confirm the diagnosis, because if your case is positive for BRAF V600E, this will sorry, I'll show the biopsy also. This shows diffuse infiltration with such kind of cells, and there is pericellular fibrosis. The molecular diagnosis can be done on the basis of BRAF V600E. Here, if you have a negative case, that will only show a 96 base pair and 201 base pair band peak. If it is a positive case, such as this patient, you are seeing an additional peak of at 143 base pair. So this case is positive. Why we need to figure out whether it is positive or not? Because if your case is BRAF positive, you can give proteasome inhibitors in this patient and they'll respond drastically. Your symptoms will resolve better. If your case is BRAF negative, it can still be a hairy cell leukemia, but MAP kinase pathway will be involved. The response to cladribine may not be that good. Then this may be a variant which will require addition of rituximab. So there are many other things. So to avoid all such complexities, it is better that you document the molecular signature in such kind of patients. So there are many other, since I've already taken 45 minutes now, there are many other applications also in hemato-oncology practice that I could not cover. They include the APML diagnosis, management and monitoring. See, as you heard me about the CML. So APML is a medical emergency where if you see a case which has bilobe nuclei, hypergranular blast looking like abnormal promyelocytes, you immediately advise an RT-PCR or FISH for PML RARA, and such patients have to be immediately started for ATRA, and they will be monitored based upon the baseline RT-PCR transcript, which is BCR 1, 2 or 3, followed with the same kind of RQ monitoring, BCR 1, 2, 3 respectively. We also can use mid 88P to 65P molecular signature in confirming the diagnosis of lymphoplasmacytic lymphoma. If you are doing a CLL-IGHV mutation status and you find that it is mutated, which means there is less than 98% similarity to the normal reference sequence, then this patient will behave better in response to treatment. If the patient is young, less than 40 years of age, the response will be better to FCR regimens if the patient has a mutated status. So there are other conditions like myeloid neoplasm with eosinophilia, which I already discussed. There also, if you have classical signatures, you will use the specific inhibitors and you'll get response. In CMML, there is not much role as far as treatment is concerned, but if you have a molecular clone available, molecular mutation available, that helps in substantiating the diagnosis, number one. Number two, it helps in prognostic scoring. If you have ASXL1, NRAS, SRSF2 mutations, then these patients, or if you have more than one mutation present in the patient on NGS, this patient will have poor prognosis. So you also have some classical cases where you get ring sideroblasts in your bone marrow, you have thrombocytosis, and when you do NGS, you get an SF3B1 mutation that has been separated in the WHO as an independent entity. Now, we also came across a case recently which was an AML, but simultaneously it had systemic mastocytosis and your NGS showed D816V. So we could not ignore. We went back and reviewed the slides and saw that there was mast cell aggregates both on aspirate and biopsy, and the morphology was atypical. There was aberrant expression of CD2 and 25 on flow. Apart from this, you also have a role in chimerism. Chimerism is very important for monitoring of allo stem cell transplant patients to prevent impending relapse. And it also decides whether you want to give your patient a donor lymphocyte infusion or not. Let's see with an example. Normally, your donor will have a different set of short tandem repeat peaks. The recipient will have different set of peaks. But if and ideally post-transplant, your recipient status should have all 100% donor cells. It should not have recipient cells. If you're getting recipient cells, it means if your recipient if your post-transplant status shows presence of recipient alleles, it means your transplant is failing. It is time to start donor lymphocyte infusion to save impending relapse. So such as the significance, timely intervention is definitely going to help your patient management. It will help you to decide the prognosis, act wisely. So the take-home message from my side is that you cannot think of diagnosing and treating a patient correctly without using molecular information. I'll be very happy if there are any questions. Thank you so much.
Thank you, ma'am. Thank you so much. Is there any question, everyone?
If you have any question, you can write in the chat box or you can ask ma'am directly.
There are no questions. Either I taught very badly or I taught very well.
Questions are on the way, ma'am. I think someone is writing something in the chat box.
No, what I showed mid-88 was in a fragment analysis, that is by capillary Sanger sequencing. See, for these tests, mid-88, I'm not sure, I do not have a personal experience with IHC, but I can say that mid-88 is very specific on fragment length analysis for clinching the diagnosis of LPL. If you have already documented clonal B cells and clonal myeloma cells in your flow cytometry. The next question is how to diagnose JMML. So JMML, see, first thing, the age. You should consider if it is a young age patient about less than 10 years of age and he has a leukoerythroblastic picture on the PS, he is having splenomegaly and there are monocytes which are increased. Absolute monocyte count is going more than 1000. And then if you do karyotyping, you should also rule out KMT2A rearrangement and inversion 16 kind of stuff in such patients. Otherwise, this case will qualify as AML. And if these AML translocations have been ruled out, then you go ahead with NGS, and there you need to document one of these mutations, the NRAS, KRAS, or PTPN11, or NF1 or CBL. So that is the case, I think. Then the next question is, which would be the top 3 molecular must have according to you, ma'am? In which entity, dear? If you're talking of AML, then I would say NPM, SEPA, and FLT3 ITD. And for FLT3 ITD mutation, PCR or NGS, which method is more sensitive? See, there have been discrepancies. I have come across cases where Sanger, the fragment length analysis, has been able to pick up FLT3 ITT when the NGS has not been able to pick up, because the length size has been very long. So there has been discrepancies. I would say if I have to pick one test, I will use the PCR based assay over NGS. There will be bioinformatics error, you cannot rule out, but this is FLT3 ITD information is so crucial to your treatment that you cannot afford to miss it. So if a simple test is helping you, please go ahead with it. Don't make it obsolete. What is the ideal sample for chimerising testing on post? Ideal sample is peripheral blood. Even if you see, the transplant patients would have received transfusion, so that is not going to interfere with your result. Go ahead with peripheral blood sampling. We have also tested for on buccal mucosa, but the results have more or less been the same. So you need not be bothered. No, regarding the techniques in plasma cell disorder. See, dear, plasma cells may you need to have. You should have that the FISH is the best technique as far as I feel that the most common high risk alterations are caught there. Apart from that, if you do NGS, you'll get copy number alterations, which genes are upregulated or downregulated, but that is not there in clinical practice for now. In clinical practice, or as far as the guidelines for prognosis are concerned, they are still using the FISH findings of deletion 17p, translocation 414, translocation 1416, translocation 1420, and 1q amplification. Germline 2, I didn't get the question. Can you just specify, Ramaswamy? Germline 20 by 5 is 30%.
1 minute. Hello, I would like to ask regarding you mentioned 20% cutoff, 30% cutoff. Can you elaborate that?
I'll elaborate. Wait. See, now in that case, you saw that there was a GATA2 mutation, right? At a VAF which was high. Okay. Now, if you are getting a point mutation, means you have a point substitution at one particular position, there has been a change in the base. Then you call that a point mutation. If there has been a deletion or an insertion, you call that frame shift deletion insertion. So the frame shift deletion insertions require a lower cutoff. If that is present, even if it is more than 20%, you will suspect a germline origin in such patients. For point substitutions, a higher cutoff has been designed, that is 30%, and that is according to the BGH guidelines 2022.
Thank you. But how can we know that it is a deletion, insertion, deletion, or anything for the particular molecule?
Call, no? I'll just, should I share my PPT again? I'll just share and show. If you see that case, is the slide visible, Rama?
No, ma'am, it's not visible. Yes, ma'am, now it's visible.
It's visible now? So
Yes,
see, the GATA2 mutation is a frame shift deletion. It's written here. Can you see? Your pipeline will call, the bioinformatic pipeline will call your case. What kind of see, EZH2 is a non-synonymous, means it's a missense mutation. ZBP1 is a missense mutation. NRAS is a missense mutation. ASXL1 is a frame shift insertion. And your GATA2, because you're interested in GATA2, because there are 6-7 genes which are known to have germline predisposition, such as ANCA-D26, GATA2, SEPA, TP53, and there are 2 others also, ETV6, and there is one more. ETV6, I'm forgetting one more. So these 6-7 mutations, you have to be very cautious. So you are getting a frameshift deletion in GATA2. So even if 51, if it was 25%, then too you were supposed to be suspicious about a germline origin. Any other question?
Because it is a deletion. Because it's a deletion.
Yes, it's a frameshift deletion.
Because if it is a 50%, then straight away everybody can understand probability of germline mutations. But the same, if it is a 20%, because of this deletion type, we have to think of that.
Yes. See, I will share this. Can you see this screen? Wait, no. Oh, sorry, wait. I have one slide. I just hid it because I thought we'll be overshooting time. See, this is the paper we are referring to where they have given clear-cut instructions and they're talking about the cutoff of more than 30% for single nucleotide variants and more than 20% for small insertions or deletions. And these are the 6 genes they're talking about: DDX41, SEPA, RUNX1, ANCA-D26, ETV6, and GATA2. And they say if you get such kind of a case, you should write a statement that this may probably be of germline origin. So I didn't share it because I thought I will not have time, but you guys thankfully raised the issue and I'm very happy about it.
Thank you so much. Very lucid.
Thank you. Any other questions?
Yes, ma'am. There is another 2 question.
Yes, please. There are some questions. It is which method is more sensitive for CML, MRD, and RQ? RQ is more sensitive. If you have a fusion transcript present, try to follow it up with RQ-PCR. And can IGH translocations be? Yes, absolutely. That is the detection method of choice, IGH translocations. If morphological diagnosis is CML and BCR-ABL P210, 190, 230 is negative, is there any? I think I showed you the atypical transcripts, no? Usually if you use the expanded set of primers, you can detect almost all the breakpoints that I showed. So you will not need an NGS. If you do an NGS, it will become very easy. But why would you want to spend 10,000, 12,000 when you can simply do a 2,000 car, 1,000 car test and find a confident result? So I don't think that's required. You can use it at the time of MRD monitoring. Yes. Are you clear or you need some more?
No, ma'am.
Okay. I can't see any more questions.
The chat box is clear now. Is there any more question?
Feel free to share. Even if you feel it is very silly question, please share, because this is how we all started. We should not feel shy. We should speak, even if it is not relevant to anybody else. If it is relevant to you, I will answer.
Ma'am, I recently had a similar case like CML, where the cytogenetics was 99% positive, and bone marrow aspirate and the biopsy was consistent with CML. And the thing is, P210 and 190 has come negative. But the patient has already been started on imatinib, and presently the CBC count, the WBC count is 10,000. And we don't have the diagnostic sample, just in case like a month later the patient will be returning for the follow-up, to find out regarding the atypical CM BCR ABL. After a month, when the CBC count is completely normal, can we still go ahead and do the test?
You can do, but you will have to do a nested PCR.
Nested P. Okay.
Same set of primers you use, but then you amplify it one more time. You use the PCR, first round PCR, and repeat the same set of primers to amplify it further. So nested PCR will definitely clinch the diagnosis. I don't think that should be. We have had cases and we have been able to document successfully. No problem.
Okay, sure. Thank you, ma'am. Thank you.
Welcome. There are few very. In any comments in cases of BCR ABL monitoring using RQ-PCR using Gene Expert platform? I have not used it. I'm using the Roche platform. So I do not have any personal experience there. I'm sorry. Does recent blood transfusion affect? And no, molecular diagnosis is not affected by recent blood transfusion. It has got nothing to do with it. Ma'am, AML, if the molecular shows both favorable and unfavorable molecular, in which risk will it be? That, okay, okay. See, I'll go back to my slide again. So look at this slide. The ELN says that the common translocations are favorable. Your NPM mutation without FLT3 is favorable. Your ZIP mutated SEPA is favorable. And all these translocations listed here are unfavorable along with complex karyotype and AML MRC mutations and mutated TP53. You are asking me, if you have both, what will you consider? So take for example, if I say I have only translocation 821 and I have this ASXL1. So the guidelines are pretty clear that if you have a favorable category and you are getting some of the cytogenetic abnormalities which are associated with AML MRC, then that case will upgrade to adverse. But if you are getting AML MRC mutations, that case will not upgrade to adverse. Are you getting? Have I been able to explain? Let me try it other way. See, the favorable has to be decided, the future has to be decided on the basis of MRD analysis, number one. Number two, in case of NPM, they have given a rider that if NPM is present without FLT3 ITD and you get along something called monosomy 7, that case will become adverse because NPM associated with MRC related adverse cytogenetic abnormalities will become adverse risk. But NPM with AML MRC mutation for the time being has not been upgraded. Similarly, translocation 821, if you have a FLT3 associated, you have a KIT associated, it does not change your risk categorization. So all this is so complicated that ELN also thought we need to find a simple way for our users, and they said that for the time being, for favorable, you Sida go to MRD. Are you clear now? Gaurav?
Hello.
Ramaswamy, please speak.
We are very clear, madam. The last one. But in the context, suppose KIT is showing the 816 or 820 mutations, which according to some authors carrying a poor prognosis. Of course, ELN has very clearly said it is not being taken as
Yes.
the bad risk. How to go about it? Is there any difference
You
between
can go
NCCN?
about it. See, you do an MRD analysis. Obviously, if it is KIT, it is going to show resistance to therapy. There are KIT inhibitors also. You can add some directed TKI therapies in this. I think pacritinib or some drug is there that can be used in such patients. So that can be tried. There is no harm in it. But then you should first assess your MRD results and then take the future call. Secondly, you said if D816V is present. I told you that I recently got a case which was translocation 821 positive, and then I came across mast cell clusters, and it came out to be D816V positive. No, that case was not translocation 821. Sorry, that was a simple AML, and I got D816V, and then I went back and saw mast cell proliferation in that case. But your translocation 821, if it has a KIT, wait for the MRD, and if your MRD is positive, go in for adding a TKI like pacritinib to attain remission. Rama, are you satisfied? Gaurav, you have anything to say? So I can't see any further questions. Thank you, Gaurav. Thank you.
If there is no other questions, so can we just end the class here?
Yes, we can.
Okay, so there is no any questions popping in the chat box. So thank you, ma'am, for taking the class. Thank you, everyone who has joined the class. Hope to see you again as the faculty of this masterclass, ma'am.
Thank you so
Good
much
night, everyone.
for
Good
this
night.
opportunity, and I really hope I've been able to justice to the job at hand. Thank you so much.
Thank you. Thank you. Thank you.
Bye, everybody. Good night.